Wow. I can't believe that many people showed up to hear an endodontist talk about implants. I hope I don't disappoint. Okay, welcome everybody. My name is Samer Ibaid, and it is my absolute pleasure to be speaking to you tonight. This is the 5th time I speak to the Dental Society. 2001 was my first year, and I spoke about endodontic surgery. Then 2006, I spoke to the practical approaches to endodontic diagnosis through. Thank you so much. And last week, Dr. Schaefer sends me a complete outline to that lecture. After 19 years, he has it, and it's right here. I was very impressed, very impressed. But this is not a lecture that you need to take notes. Just sit back and relax today. And 2003, we spoke about CBCT. Last time I was here, I was in this corner talking about atypical alveolar neuralgia. Today, we're going to talk about endo and implants. Now, what does an endodontist have to do with implants? We'll talk about that. Learning objectives today. I want you to expand your horizon in decision-making and diagnosis when choosing between endo and implants. Gain a deeper understanding of possibilities and long-term potential success for endo treatment. Do you see where I'm going? Endo. Develop confidence in treatment planning by applying evidence-based principles and treatment plan with confidence. And at least learn one thing tonight. Just one. That's my objective. Most importantly, relax and have fun, and hopefully you will enjoy this. Now, I want to give a hands of welcome for the residents and the UOP faculty. They're over there getting food. These four lawyers, endodontists, they do look like lawyers, just achieved the Herculean task by surviving the UOP endo program, which is not easy. And I want to ask you guys a question. Would you do it again? Yes, see that? That's a testament. Without the tuition, of course. I don't mean that. So Dr. Niha Dawar, Dr. Amro El-Khatib, Dr. Michael Glenn, and Dr. Gabriel Murphy Echeverria, it's his birthday today, so congratulations and happy birthday. Decision-making for endo and implants. Hopefully this is not one of the decision-makings. I don't know if anybody, this is AI derived, of course, but I hope no one in this room would choose that. So have I ever done an implant in my life? And the answer is yes. I've done 9 implants in my life because I was invited in 2019 to be part of a mini residency, and we went abroad to Cairo, Egypt, and we worked in the OR for 4 days. I did 9 implants, and we learned a lot. I learned a lot. I saw a lot of grafting, a lot of techniques, and it was something that I enjoy truly. Not bad for an endodontist, huh? I wasn't happy with the healing screw, whatever you guys call it now. So last time I checked, all 9 implants are doing well. So my record in implants is 100%, and I'm retiring at that. I wish I can say that about endo.
Did you have a desire to obturate the screw space at any point in time?
It was a fantasy of mine, but I can't share it, but you can, right? Getting all the way down to the apex. Okay, disclaimers. We have to keep the lawyers happy. All my clinical images presented in this lecture are authentic, and no digital manipulation has been applied beyond brightness and contrast adjustment to enhance the clarity. The treatment protocols and philosophies discussed reflect my own clinical approach and experience. I fully acknowledge that multiple valid treatment strategies exist with the scope of evidence-based endodontics. This presentation is intended for educational purposes only and is not meant to dictate a single standard of care. Radiographic and clinical outcomes presented are individual cases and may not reflect all clinical scenarios. The concepts discussed include potential healing outcomes of endodontic lesions, may challenge conventional thinking, but are supported by my observed outcomes in my own practice. Now, sphenopalatine ganglioneuralgia. Let's start with something simple. Does anybody know what that is? Okay, all right. I have to teach you something then. I was hoping that this is the thing that I have to get out of the way by teaching you one thing tonight, but Michael, I have to teach you something new today, okay? Because you called it. He's right, it's brain freeze. It's a scientific name for brain freeze. If you didn't know that I fulfilled my prophecy and I was going to teach you something, you learned it, so at least, Michael, I'm gunning for you. Okay, this 20-year-old young man, perfect teeth, good-looking mouth, and he's 20 years old, his life expectancy is 100. So we have to carry this young man for 80 decades, being as close to this picture as possible. That is my philosophy in practicing dentistry, and I believe we all have similar philosophies as well. So we want to do what's necessary, and prevention is key, obviously, but when it comes to endo and implants, is you're fixing a problem. This is not what we want. This is not what we are shooting for. We're trying to avoid something like that. Okay, so I am pretty known for condemning teeth pretty quickly if I don't think I can bail them out. But I'm also known that I do crazy stuff and be crazy, like Dr. Satuda just called me yesterday or the day before. But it's true, I do handle some crazy stuff if I think I can heal it. But stuff like this, and I know it's a fracture, I am the first person to condemn it for an implant. So this person referred me and he goes, hey, Ibaid, one of our favorite patients just condemned the tooth or confirm it, and if you can work with it, send it back. So I said, sorry, this is a fracture and time for an extraction and an implant. I'm not shy for doing that. I don't like to try and see and hope for the best and all of that. That's not my philosophy. So as an endodontist, we do a few things. Vital pulp treatment, necrotic pulp treatment, periradicular lesions, acute periradicular infections, endoperio, endosurgery, and we're going to touch on a few of these today. So the most important thing that an endodontist does is decision-making in diagnosis, rendering a clinical judgment. Now, this is the majority of things of what we do, but we don't have enough time to discuss that today. So we're going to bypass the decision-making. You just have to accept it, I guess, and be your own judge. All right, we're here to talk about endo and implants. Let's see what endo and implants have to offer. Are they both successful? And I argue yes. The initial root canal treatment is 85 to 97% successful to 10 years. And it says success depends on coronal seal, quality of restoration, and periodontal health. They don't discuss anything about the removal of the organic debris, which we will talk about. Non-surgical treatment, of course, if it's done, if it's not working right the first time, it's not going to have the same result. So 75 to 80%. Apical surgery, 90 to 94%, and I do believe that. However, it needs to be done right. Endosurgery is difficult, and it's not easy to do. You think you did it right, but sometimes it's not, and I've done both, endosurgery, and I've done 9 implants. Ooh, 9 implants. Endosurgery is a bit harder. So single tooth implant, 90 to 95% for 10 years, high survival rate. I highly believe that is accurate. However, implant survival, 95% survival, but 80 to 85% success, because success is not survival. That applies to endo and implants. And we're going to go over that a little more. 15 to 20% of implants fall victim to peri-implantitis, which is a biofilm infection. And all the periodontists in this room, and most of them are here, will agree with that. Decision making, that's where it starts, that's where it ends, that's where it happens. So how many decisions do you think an average person makes a day?
Less is more.
Less is more. Ira, I'm so happy you're here. You have no idea. Yeah. No, can anybody give just how many decisions does an average person make in a day? 100? 500? That much? Okay. Hey Siri, how many decisions do we make on an average in a day? Did I trip any phones?
What? No way.
Okay, that's an average person, okay? We are not average people. We're crazy individuals. We're dentists. So how many decisions do you think we make a day? A lot. Okay, look at 30,000 decisions here, mostly surviving. Those are subconscious decisions that you're not conscious about making. You are going to make a few tonight, every single one of you, okay? So first, let's make a decision here. Restorability, tooth number 2, obviously. This is the PA and a bite wing. Would you treat it with an endo, put a crown on it, or would you extract it and put an implant? Think about it. Okay, this guy, I'm interested to hear from the residents. What would you do? Well, I'm going to tell you what I recommended. It took me 5 seconds to condemn this tooth and put an implant, okay? Because look at this. One canal was found. This is lower first premolars are either the easiest or the hardest teeth to do, okay? This tooth, it looks like there's a missed canal here. I guarantee you there's 3 or 4. Look where the lesion is. It's not where the missed canal is. And most importantly, look at up here, okay? What is the ultimate restorability of that tooth? And I look at it like that and say, yeah, can I try to do an endo? Yes, I can, but we are not treating, I don't like to treat x-rays. So in dentistry, making decisions, in endodontic, success means more than filling canals. It means honoring the trust that everything built on that tooth will stand over time. We are not defined by the procedures we perform, but sometimes we are by the decisions we make before that we ever pick up a handpiece. So look at this. What would you do? Tooth number 29. Look at the scan as well. Tooth is very percussion sensitive. Pulp is necrotic. What would you do? Endo or implant? All right. What about this tooth? Tooth number 19. Pulp is necrotic. And would you do endo on that tooth? Yeah? What if I tell you there's a 10 millimeter pocket on the distal, on the facial? Would you do endo on that tooth? You would? Okay, what if I tell you this is what it looks like?
Oh my God.
You still would do endo on the?
Medicated.
At UOP, right? Okay, look, I'm going to teach you something tonight, so you figured that brain freeze. All right. Okay, what about this guy then, Dr. Glenn? All right. What if I tell you it probes in the mesial and it probes everywhere else? Any takers for endo? What if I tell you this is what it looks like? Any takers? I like you. Good. What if I tell you this is what it looks like? You would do it. Good. That's Amro, you're my man. Easy endo? They're all easy. Easy implants? I don't know. There's no such thing as an easy implant. But think about it this way. Okay, this tooth, what would it take for an implant to happen? Extraction, bone graft, but from what I learned in my minimum implant experience is vertical bone regeneration is unpredictable. Is that true? Yeah. I mean, if you have the walls and you can regenerate them, but this is unpredictable. What about this guy? Okay, would you do endo on this tooth? Buccal sinus tract. What if I tell you if it looks like this? Where do I come up with these cases, right? I get them every day. I really do. Easy endo? Maybe. Okay, this is a case from Dr. Differding's office. Easy endo? Anybody can do this, right? Would you do endo on it, Ambro? I would too. But what if I tell you it looks like this? You would. Okay. That's because you don't know how to do implants, right? Okay, easy endo, easy implant, do it or not. Mobility of 2, by the way. Okay, what about this guy? This is a benign case. Would you do endo on it? Now, there is a sulcular breach, and we probe all the way down to the apex. What if it looks like that? Would you still treat it with an endo? Okay. So you don't have to give an answer. Just think about it. Make a decision in your mind. How many decisions so far? What if I tell you this is the tooth? Would you still do endo on it? You would. Okay. All right. So Dr. El-Khatib will do endo on all of these cases, by the way. I just want to put that on the record. No, I love that. That's good. Okay, let's divorce ourselves and see how endo can save the day. A 63-year-old Caucasian male, ASA3, heart transplant 2 years ago. Recent upper left pain, quadrant pain, referred for evaluation and treatment. Now take a look at this. Okay? Now why did I say heart transplant? What significance is that? The anti-rejection medication, okay? The depressed immune response. Hold on one second. I'm going to show you, I'm going to go into one scan tonight because this is important. Okay, let's take a look at the axial view. We're looking at the upper second molar. This is the tooth. Oh, you can't see it? Okay. Okay, so the upper second molar, this is the tooth. And look at the lesion, how big that is. Second molar. And this is a lesion up here, the sagittal view. Endo implant or something else? Dr. Amaya? No, I mean, what would you, no, seriously, I don't, no. Then I get a consultation from Dr. Amaya saying, how's the perio? No, I mean, is there another option besides endo and implants? Well, exactly, extraction. Extraction, and would you replace it with an implant? No, okay, that's wonderful. But I want you to take a look at this. We're going to do this again. Look at the axial view. Look at the tooth in front of it. Look at here. You see this? I can't even. Forgive me, everybody. Okay, let's take a look here, because I can't see the scan on my screen. Take a look at here. What is this? What do you guys think? It is a fracture. It's a fracture of the first molar. So if we extract the second molar, the first molar has got to go, and we would have collapse of the left maxilla. And I like Norm. I didn't want that to happen to him. So I said, okay, let's get things done. So I recommended an implant. An endo, not an implant or an extraction. So we did the endo, and this is what we have. Bone regeneration after a year, okay? And we see everywhere that the bone is healing. And this is 1 year post-op. This is what we started out with. And this is 5-year post-op. And Norm is doing great, health-wise, dental-wise, and otherwise. As a matter of fact, I saw his wife last week for a consultation. And I was happy to tell him she didn't need an endo. Any questions or comments? And he's happy with the second molar occlusion, by the way. No? Then what is endodontics? Maybe I wasn't fair to you. Let's define endo. Endo success isn't just about sealing the canals. It's about securing the patient's comfort, preserving the function, eliminating chronic disease, and protecting every restorative step that comes next. That's a philosophical way, but what really is endo scientifically? Endo is to prevent and to treat periradicular periodontitis. Is that the going definition? Pretty much. Well, what does that mean? To prevent and to treat. I hate the word treat, because treating is you're applying a technique, whether it works or not, but that's not the way I look at it. My definition is to prevent and to heal periradicular periodontitis, but an extraction does that. But if you do it through the most conservative means, then that would be properly addressed. Now let's take a look at this. This is the endo outcome studies from 1956. From 1956 all the way to 2004. It's all over the place. To you is that there are so many variables that this is very hard to do. So what matters is, what is your success? And we're going to cover that a little. Now, let's go back to the original question. Endo or implant for tooth number 2? Who would do an implant? Who would do endo? Good job. Because if you do endo correctly, things work out. This is not fake. This is real. And Dr. Lai here helped me with the digital art right here. He goes, send me a scan. I sent him a scan. An hour later, he's sending me this. This is what the tooth looks like, the post-op scan. And when we look inside the tooth, we can see the anatomy of the canal.
Wow.
Yeah. I call it the Freddy Krueger tooth. Everybody that I show this to, all the endodontists, one comment: I've never seen this before. I said, that's exactly what I said. And I told the patient, I've never seen this before. She starts laughing. She was lovely. And I said, whatever it takes, we're going to make it work for you. Anyway, but this was not the hardest tooth I've ever done, by the way. So, and with a good build-up and a good contoured build-up, I think this tooth is very restorable. And I saw her for the 1-year post-op, and she hasn't had the tooth restored yet. And I said, why? She goes, I found out I was pregnant the next day. And I said, okay, well, I'll go get a crown. Now, what is the rationale of endodontics? Endodontics, we have pulpal disease migrating from coronal to apical, and from all the portals of exits, we can get bone inflammation and endodontic lesions. And so what do we do for doing endo? We access through the tooth, irrigate the canal, clean and shape the canal, and disinfect the canal, because we can't sterilize the canal. There is no such thing as sterile in the oral cavity. The oral cavity, once the baby cries, you're not sterile anymore. Then we fill it with something pink called gutta percha, and we wait over time, and the bone heals, and good night. You tell your kids that story, and it works out. Yes, it does work out, actually. I'm not a pessimist. It does work out. So my favorite study, old study from 1965, Shiguri, I think his name was, Shiguri Kakahashi. He got a brilliant idea of getting 36 rats, 21 of them were notobiotic. That means they're germ-free. No bacteria in them, on them, food is sterile. I don't know how they achieved that. And it was a feat back in 1965, and 15 normal rats. They exposed the pulp, let them sit for 2 weeks, and found out, and they looked at them histologically, and all of the notobiotics rat had dentin bridging and no periapical pathosis and no lesions. All the other ones had endopulp necrosis and the beginning of lesions. So they concluded that it has something to do with bacteria, and they were right. I hate this mouse. Anyway. So 1676, 100 years before the United States became a country, Antony van Leeuwenhoek saw bacteria for the first time. And he got it from dental plaque. So he looked at dental plaque and he saw things swimming. And that was bacteria, and that was the first time bacteria was mentioned. The disease flow is coronal to apical. The bone lesion develops as inflammatory sites due to bone biofilm byproducts such as exotoxins and proteolytic enzymes. So you get any portal of exit, and adjacent to that portal of exit, you get bony inflammation. And you hit an endo-perio interrelation if it takes the path of least resistance and it blows through the PDL. Now let me ask you a question. Do lateral canals exist? Well, fortunately, in our community, we have endodontists that believe in it, demonstrated it. We're educated by the people that started all of this, and we do believe that lateral canals exist, and they are significant. They are important. Now let's take a look at this case. This is a case that was referred to me by Dr. Melissa Rink. Tooth number 5. Classic symptoms, cold sensitivity, wakes up at night, started 2 days ago, takes some Advil, feels better. He comes down and we diagnose irreversible pulpitis. He is a busy person, and he said, okay, fine, I'll make an appointment in a couple of days. A couple of days later, the day of the treatment, he calls and he says, I'm fine. I want to cancel my appointment, I'm fine. We strongly recommended against that, but he didn't listen to us and he disappeared for a year and a half. So he comes back a year and a half later, and by the way, this is the pre-op scan when he had pulpitis. A year and a half later, he comes, and this is what he has. And I showed him this on the monitor, and his eyes bugged out. He goes, "That hole is in my head?" I said, "Yes, it is." And at that point, he was fine with any treatment. But then again, COVID hit, and everybody was working from home. He didn't have to travel, and everything was Zoom. And this is the axial view of that lesion. Can you hear me okay? Is the microphone okay? All right. So this is pretty big. Now, Amro, would you do endo? On what?
Number 5.
On number 5. Good. We agree. So I did endo on number 5, and this is the final. This is 6 months, and this is the year follow-up. And by the way, I follow up cases like my kids, okay? I have excellent staff that would call and remind, and I tell them your life depends on it, and they get it done. So, and I really appreciate that, by the way, because unless you see it for yourself coming from your hand, you're not going to know, because an outcome study does not give it justice. So this is the lesion before, this is 6 months, and this is a year. This is what we had before to start with. So it's very congruent with what we started out with. And remember, I had the pre-infection scan because he came in with pulpitis, right? So comparing it, it's the bone has regenerated to the same manner. Now let's take a look at this. This is the before, this is the after. This is the healing. Now take a look at this. Do you see the buccal plate? It has regenerated in exactly the same manner and same position as before. We're going to come back to this case later for demonstration purposes, but this is all due to bacteria. And we all studied bacteria in school. Bacteria, the unicellular organisms, and they're single cell, they're prokaryotes, and they're very, very fragile. But bacteria has been cited to be on Earth 3.8 billion years ago. How can a unicellular organism like that survive 3.8 billion years? And they will probably outsurvive us. So if you are going to study bacteria, you want to study bacteria in their original habitats. Not you take an isolated sample and you look at it on the microscope and draw conclusions, because this is not how things are in nature. So, for example, you get 2 aliens that are had just discovered Earth, and they go, "Who do you think lives down there?" And you get an answer like I believe they're called humans, Beavis, because we know that butthead is a smart one. So they get samples from Earth and they study humans, and this is a good description of what a human is. And this is also a good description of what humans are, right? Would you agree? But this is not the true reality of how humans are, because humans come in many societal and functions, like military, transplant teams, where there is a huge amount of interaction going, and global finances, and the world is coming to be much closer because of communication. And bacteria does the same thing as well. They communicate, they live in society, and they are called biofilm. They don't exist in planktonic form like this, unicellular, unfortunately the way most of us have learned in school. This is the true reality of bacteria. They exist in biofilms, and this is how they survive. But this is how we studied it in dental school. Streptococcal pharyngitis, bacterial meningitis, pneumococcal pneumonia, gastroenteritis, gonorrhea, typhoid fever, diphtheria, pertussis, tetanus, and septicemia. Those are all bacterial infections that can kill you. Okay, they're caused by planktonic bacteria that will either do one of two things. It's either we kill them or they kill us, one or the other. Now take a look at this lesion. Amro. The patient is 100% asymptomatic, did not know this was happening. Okay, so why is that? You have a lesion like this and the patient is asymptomatic. Where is that coming from? It's coming from biofilm. Not saying that this case is, but extraradicular biofilm exists, and this is eficalis, by the way. By the way, this is the apical foramen, and what the bacteria is doing is creating its own food by creating minor inflammation in the body, so it's making its own food. It's a parasitic infection, chronic infection. And this happens with implants as well as periimplantitis. And we can see it here. It looks beautiful on the outside. Take an x-ray, it doesn't look so well. And we open it up surgically. Do you see the junk? So biofilm is dangerous, but it's not always dangerous. There is 10 times more bacteria in you and on you than your own cells. And there's 100 times more bacterial genes in you and on you than your own genes. So you're either 10% human or 1% human. You can decide. But with that biofilm, we cannot exist because the biofilm is not always harmful and it protects us from a lot of harmful bacteria. Any questions or comments? Good. I'm going to go fast, if you don't mind. Okay, let's go back to this asymptomatic lesion. Look at this. It's pushing away. It's distending the IA canal, and the patient is unaware of it. So what do you think the outcome for doing this the retreat is? Statistically 75 to 80%, right? In your hands, what is it? If you do 100 of these, how many are going to survive? If you do 10 of these, how many are going to survive? 80 to 90%? Yeah. If it's done well, 100%, right? And what's done well? Removal of the biofilm is very simple. Remove all the biofilm and things will heal. Now let's go back to the challenges, and Dr. El-Khatib will do every single one of them. Now, that's a choice. That's a decision that you have to make. Really. There is no right or wrong answer. If I look at this and I say, this messed up tooth, and I say, no, I don't think I can do it, then don't do it. Okay? But if you say, I'm pretty confident that this thing can resolve, then go ahead and do it. What about this guy? This one bothers me a little. This is depressible. It's class 3 depressible, by the way. Okay, in dental school, we learn endo by doing extracted teeth. And we are offered a formula, a recipe. Ideal access cavity, identify all canals, achieve patency, working length file, radiographic confirmation of canal length, irrigate with sodium hypochlorite a few times. Glide path is very important. Then we use rotary instruments, 25 for the small canals, 30 for the large canals. Irrigate with sodium hypochlorite again. Cone fit, confirm the cone fit. BC sealer with cone fit. Sear the gutta percha, clean the access, put a temporary restoration, take a picture, and you get credit. It's easy. If we do that, this is how we all learned. Well, we have to start somewhere. It's like a chef learning how to cook by given a recipe. We all have to learn by doing recipe. And you get an A+. So you graduate from dental school learning this. Treatment X, which is actually technique X, equals result Y 100% of the time. If you apply that technique, that recipe, you're going to get 100% success everywhere. Now, there's something in the law called legal justice. Legal justice is application of the law. It's the application of established rules, laws, and professional guidelines and conducts to achieve fairness and consistency. But it doesn't always guarantee that the outcome of the most ethical is the most ethical or compassionate choice. So the legal justice is, am I following the rules? And let me refer back to some people that are old enough to remember a big national murder case back in the mid-90s where the defendant was acquitted, but the defense lawyer admitted that legal justice was achieved. However, he wasn't sure about moral justice. And I don't know if you guys can draw to who that was or not, but the lawyer himself was saying, we achieved legal justice, and this is what we're here for, is we need to achieve legal justice. Moral justice is not what we deal with. I disagree.
So who was it?
I'm not going to say.
If the glove doesn't fit, you must have quit.
What glove? So moral justice, legal justice versus moral justice. Okay, on a better note, Ira, okay, the French Laundry, okay, in Yountville, voted best restaurant in the world twice. Our governor seems to like it. Good example of the culinary art and the perfect example of where science, creativity, and art meet. So, this is Thomas Keller. He wrote a book, French culinary book, which I have right here. Amazing book. And I've tried to do recipes out of it, and I've succeeded, but I'm no Thomas Keller. What I'm trying to tell you is it is more than following a recipe. A recipe is just a framework. What makes a dish exceptional is the chef's skills, their intuition, their timing, and the way they adjust ingredients without measuring. Also, it's the atmosphere they create, the things those things cannot be written down. They are the products of experience and good judgment. Dentistry is the same way. The textbooks and guidelines, they are just our cookbooks. They are our recipes. The essentials, but they don't replace the clinical intuition, experience, and human judgment. Following a recipe is like legal justice. Applying your experience and skills to serve our patients' best interests is analogous to moral justice. Okay, let me give you another example. Think about Tiger Woods. He isn't just good, he's unique. He's the best at what he does, consistently professional, and when it matters the most, he delivers exactly what needs to be delivered. Let's take a look at him. Now look where the ball is, and look where the hole is. What is he doing? He's putting it here. That makes me smile every time I see it. And I've seen it 100 times. Tiger Woods was not following a recipe. He executed the score in his mind before he even putted. Okay, what is endodontic success and outcome? Where's Darren? Does that make... Darren and I went to the program that cemented this in our minds, which is endodontic success has 100% potential healing minus X, which is the endodontic factor. The endodontic factor is basically you. People think that we coming out of Boston University think that endo has 100% success. That's not it. The philosophy is that it has 100% potential success if you do everything right, if the diagnosis is right, if you remove the organic debris, if you find all the canals and all of that. So it puts the burden really on you, okay? And this is how we grew up, right? It's, so this is the way I define endodontics. I mean, the process of endodontics. Proper diagnosis, profound anesthesia, hermetic isolation, removal of all the organic debris, aseptic technique, which is very important, aseptic technique. Most people don't emphasize that enough. Seal the root canal system in 3 dimensions, occlusal restoration with proper occlusion. And it's got no numbers, it's got no files, it's got no repetition, it's got just figure it out and do it. So let's go back to this. Decision. Endo or implant. The patient is there for your advice. So I did endo, and it looks beautiful. Success. Gabriel's looking at me bad. Well, we have to follow that success to know that it's success. 6 months later, the bone resolves. We don't open this thing up surgically, because if you do, the best you're going to get is a long junctional epithelium. This is an true endo-perio interrelation. It will heal spontaneously by itself in 6 months, and we're going to be fine. So whoever called endo, good job. It gets a little harder, okay? What about this case? Endo or implant? Endo. Do it. Why not? And 6 months and 12 months. Okay? So this is the 6 months and this is the 12 months. Good healing, I think, right? Patient is happy. And this is the 2D x-ray. Okay, this case. My diagnosis was messed up tooth. Endo or implant. Now, implant, is this an easy implant for the people that do implant? I have really no idea. It's not a straightforward thing. The bone is infected. It's all bone loss here. So would this be predictable implant? No. I don't know, because I don't do implants, because my success in implants is 100% because I did all 9 cases. So anyway, so this is what it looks like on the scan. So I did endo, because remember, that's all I know how to do. And 6 months later, I'm seeing bone develop, but I'm not happy with the amount of bone that's developing, because this is minuscule for 6 months.